Congress. Thank you.
Thank you. Next, I would like to invite Dr. Shamira Perera to speak when to remove the lens in primary angle closure disease.
Thank you very much for the kind introduction. So you've already heard how Prof. Tin Ong has explained how we've gone about looking at the correct management of PACS eyes. Now, what I'm going to talk to you about is the next quandary. What do you do about eyes with PAC and high pressure and those with PACG? Which is the better treatment? Is it lens extraction or is it laser or is it laser PI? These are my financial disclosures, none of which are relevant for this meeting. Now, it's very impressive to have so many of you here on such an important topic. And as you know already, that primary angle closure glaucoma is a leading cause of irreversible blindness. And we know that the crystalline lens has a major mechanistic role. So lens extraction of a clear lens might be the useful initial treatment. We know already that if there's a cataract, that's the right treatment already. There's no argument about that. But what about when there's a clear lens? Well, there's already some evidence for this, even from AIMS here. This is a study by Tanuj Dada, and it shows to the impressive effect of clear lens extraction in reducing the IOP, widening the anterior chamber angle, and reducing the need for hypertensive medications. The IOP went down from 27 to 13 in this particular series of 44 eyes in PAC cases post-LPI. Our study, which I'm going to show here, which we were involved with in a small degree, was originally set out by Professor Azura Blanco. And the purpose was to assess the efficacy, safety, and cost-effectiveness of clear lens extraction compared with laser peripheral iridotomy. This is an impressive study, mainly because it was looking at things like cost-effectiveness and quality of life over things like the usual safety and efficacy parameters. It was a multi-center RCT done in 30 eye hospitals across 6 countries. The main endpoints, as we explained earlier on, was the patient-reported health status, the intraocular pressure, and the incremental cost-effectiveness ratio per quality-adjusted life years gained at 36 months after treatment. And the analysis was done on an intention-to-treat basis. Importantly, the inclusion criteria were a diagnosis of PACG, or PAC with an IOP, high IOP of over 30 millimeters of mercury. These patients, by definition, had angle closure, so they had to have angle closure of 180 degrees or more. They were either untreated or newly treated under medical treatment with drops. And they must have been phakic in the affected eye. They also must have been over 50 years old. The outcome measures were primarily patient-centered, from a questionnaire, the EQ5D, which looked at mobility, self-care, usual activity, pain, and anxiety. Clinical, it looked at the IOP at the end of 3 years and the economic benefits of the incremental cost per quality gained on response to EQ5D. So just in summary, it's a multi-center comparative effectiveness randomized control study. And it was looking at whether lens extraction or LPI was the better treatment for PAC with high pressure or PACG. Now, these patients had to have pressures of over 30 in this particular group and had no visual complaint from cataract. And they were randomized on a 1-to-1 basis for clear lens extraction or iridotomy. And they arranged about 200 eyes in each group. After the randomization was done, which by computer, you could see the 2 groups that were diverging. And one received the lens extraction, and the other received the LPI. Then medications were increased until there was a maximum tolerated medical therapy, and then there was a failed lens extraction on one side or failed standard of care, the LPI on the other side. And then the patients would proceed to glaucoma surgery. So to look at the results. Now, looking at the results from the quality of life perspective, you can see that there was a benefit of those having the clear lens extraction at the 36 time point period. A small benefit, but definitely significant. Also, you can see on IOP reduction, you can see a benefit for the clear lens extraction. It's only 1 millimeter of mercury difference, but it's statistically significant at the 36-month time point. Now, looking at the effective medications, again, it was beneficial to the clear lens extraction group compared to the LPI group. Now, looking at the additional glaucoma surgeries, you can see in the LPI group, there was several having lens extractions later on, and you can see that 6 patients had a trabeculectomy. Some had an eye stent and 1 had an RMED tube. This compares to just 1 patient having a trabeculectomy in the clear lens extraction group. If you look at the visual acuity differences, you can see again there was a benefit for the clear lens extraction group, which is a bit of a surprise because you thought they'd had no visual problems. However, even at that stage, there were probably some small amount of cataract appearing that by removing that, rendering the patient emmetropic, they were able to get some improvement in their visual acuity. There were complications in the clear lens extraction. Thankfully, not very many. There's only 1% of PCRs in that group. And in the laser peripheral iridotomy group, you can see that there was a predilection for formation of cataract, 12 patients. So, in summary, what can we talk about the results of this study? You can see that the clear lens extraction increased the vision by 3 letters in the ETDRS chart. So, in fact, although they were visually there's no visually significant cataract, they were having some problems due to a thicker lens at that age group. Of course, that may be a small but clinically irrelevant finding. The other thing was that 61% of patients required further management in the LPI group versus just 21% in the clear lens extraction group. So again, all benefits for the clear lens extraction group. So it sounds like everything's pointing to this being the better treatment. Visual field-wise, there was no statistical difference between the two groups, but of course this wasn't powered to detect those changes. And there were several cases where there was missing data as well, so that's another point that we need to bear in mind. The complications were very small, but of course this was done by experienced cataract surgeons who were very fortunate to be trained well to do these difficult cases as well. Of course, in a general population of cataract surgeons or other surgeons, then the results may not be so good. In terms of cost effectiveness, you can see that it was an incremental benefit of having these clear lens extraction. If you look at the bar of £20,000 per year as being something that will be the barrier to having something done, you can see that there was generally a predilection towards the clear lens extraction, and this got better and better over time. But of course, this very much depends on the population tested. They only looked at the results from the UK when they were looking at cost effectiveness. And the results may vary from country to country. Obviously, looking at countries with a lower GDP per head, then it will be a slightly different equation that's involved there. The other thing is that we've seen earlier on that there are several mechanisms of block in angle closure. There's not just the pupillary block, but also plateau iris type syndrome and also lens factors as well. And if you can imagine that the clear lens extraction gets rid of 2 of those but doesn't get rid of the plateau iris situation. In Asians as well, there's multiple levels of block which may not be relieved simply by doing the clear lens extraction. Also, it's difficult to tell which eyes do have a lens problem. For example, it's hard to assess the lens vault or assess if the lens is spheriphakic just on the slit lamp. Some of our imaging modalities may help us with that. The other thing is that as the lens grows in size, it doesn't necessarily lead to a decrease in vision, but it does lead to an increase in the lens vault. And we showed in one study that maybe doing a AIOC2020 could delineate those patients who have a large lens vault, and those cases where the vision is maybe not so good, maybe pushing the patients towards a lens extraction as opposed to a LPI. So in summary, this is a very good pragmatic design study with a large sample size with low attrition rates. They also had a lot of variation in diversity, Caucasian eyes and Asian eyes, and there was a very good randomization procedure by computer. There was masking of the outcomes, and it was a double-blind study. However, there were certain limitations. There's loss of data, especially on gonioscopy, which we would love to have seen. And there was no real looking at the difference between Asian eyes and non-Asian populations. So just in summary, what is the benefits of a phaco in primary angle closure disease? Well, it gets rid of the lens, and we know that the lens has an important pathogenic part, and evaluating the lens component is not easy. It does improve the vision for our patients. This is a rare thing in the lives of a glaucoma surgeon to improve the vision of our patients, so we might as well take it now. And fortunately, the risks are low. We can target the patient for emmetropia and reduce their astigmatism and potentially even give them multifocality now with modern-day cataract surgery. Good visual acuity is not a good arbiter of when to choose LPI, and I think we've got to the answer about this controversial situation of a clear lens extraction. Sometimes it might be difficult for the doctor or the patient to get their head around this idea of performing surgery on an otherwise normal lens. And more importantly, there is an opportunity now also to add on procedures. For example, you can add on a phaco plus goniosynovitis or a phaco, plus trabeculectomy. And these are things that you might be doing for the more advanced cases of PACG. Some studies have shown that, of course, a simple phaco may not control the pressure to such a low level enough that you will get no progression in those advanced PACG eyes. But there's an opportunity with this cataract extraction to do add-on procedures. So the take-home message is, one good quality trial may not be enough to change policy. However, I think we can clearly see there were some benefits of clear lens extraction, albeit somewhat small, in patient-reported and clinical factors. There was also an absence of serious safety issues, a safe procedure to do. And the consistency of the results with relation to previous studies in this regard is also well taken into account. So this study was successful in promoting the use of clear lens extraction as a first-line treatment for PACG and PAC with an IOP over 30 in that particular 50-year-old and over age group. Of course, these results may not be so easily extrapolated to different groups. But of course, there was the very strict criteria of entry and the inability to extrapolate some of those results to different populations, especially regards to cost effectiveness, which is very much country-based. There's also inclusion bias. These patients who enrolled were quite willing to have the clear lens extraction. Some patients clearly wouldn't. And of course, there was lots of data loss. The cataract studies were also very experienced, and this leads to some of these best-case scenario results. Thank you very much. I'd like to introduce you to the APCRS study, the APS conference in Singapore next year as well. I'll be moving on to the next talk as well, straight after, for Rahat Hussain, who is unfortunately unable to be here. So, just moving on to the randomized control trial of phaco GSL versus phaco alone in patients with primary angle closure disease. Now, these are our final disclosures. Importantly, this was made possible by a grant from the NMRC. Many of you may have come across goniosynovitis, the ability to remove PAS from the angle using a particular gonio lens and a spatula. You can see that in this gonio picture intraoperatively, you can see the spatula being put into the angle to peel down the PAS. This is an area that's required a lot of interest recently, and you can see the amount of publications growing, especially in the last few years. This is because there's been a bit of a difference of opinion about this area, about how we treat these eyes. How useful is phaco GSL versus a simple phaco? Well, a simple phaco actually does a really good job. And you can see this summary statement from the AAO when they looked at the usefulness of phaco in itself. And you can see that it brought the pressure down very dramatically. And in this combination study that looked at 495 patients with long follow-up of 16 months, you can see that a simple phaco reduced the IOP by 30% and glaucoma medications by 58%. So that, again, difficult results to improve on. There's been a few studies of RCTs in this particular area of GSL, but they've not been conducted very well. For example, this one is particularly quite small. It only requires a follow-up of 2 months. So this looked at, again, the effect of goniosynovitis with phaco in patients with medically controlled chronic angle closure glaucoma. And you can see that comparing phaco GSL with simple phaco, there was no difference in the IOPs. Another study, again, small study, only 23 eyes in the phaco GSL group and 20 in the phaco group, with just 6 months follow-up, showed that, again, the IOP differences were not significant. The number of anti-glaucoma medication reduction, however, was significant. So there's a difference of opinion. Is it worthwhile doing phaco GSL, or is a simple phaco good enough? And this is what this study set out to look at. So it looked at patients having these 2 surgical procedures in cases of PAC or PACG with at least 90 degrees of PS. This could be continuous or intermittent. And these had to have high IOPs, over 21 on drops. And also, obviously, the presence of cataract. This was an international multi-center RCT involving several countries from around the Asia-Pacific region. And the follow-up was done for 12 months. The investigators, importantly, were masked to the main outcome measures of treatment. The methodology were looking mainly at clinical outcomes. The IOP was the main thing, and they were looking at patients over a follow-up of 1 day, 1 week, 1 month, 3 months, 6 months, and 12 months. Post-operatively, the patients were given a little bit of Diamox straight after the operation and standard post-op medications. And patients were given extra medications if there was inadequate IOP control, or if there's a deterioration of visual field, or the patients were getting adverse side effects or symptoms to warrant a change in the medications. Importantly, the inclusion criteria were the patient had to be over 30 years old, had a diagnosis of PAC or PACG, and have high pressure. They also had to have PAS over 90 degrees and a lens opacity that was deemed sufficient to be causing decreased vision in the opinion of the surgeon and the patient. The patient was able to give informed consent. Of course, we did not use patients who had very advanced disease, were on warfarin, and had other medical or ocular problems. Main outcome measures were IOP at 12 months, and successful IOP at 12 months was considered if the IOP was between 5 and 21 and had a reduction of IOP of at least 20% from their baseline IOP, and also they were not on drops. Standard complication rates were also collected during the study. The patient baseline characteristics were similar between the phaco group and the phaco GSL group in an important number of criteria, such as the baseline IOP, number of medications, the Schaefer grading, PAS, the split between PAC and PACG, and the axial length. These are the results of the study that show the effect of phaco alone in blue and the effect of phaco GSL in green. As you can see, the error bars overlap each other and the curves are really quite similar. When you look at it in a little bit more detail, comparing the 12-month results versus baseline, you can see that there is a difference between the two, but it's not statistically or clinically significant. Same goes for the drops as well. Although the amount of IOP lowering was quite an important amount, about 6 to 7 millimeters of mercury. Now, when you look at that important definition of success, how many are meeting that with the phaco alone? 53%. How many meeting it with the phaco GSL? 58%. So although it looks like it's better for the phaco GSL, this was not considered statistically significant. So it's exactly the same. If you look at complications, these were all very similar in terms of the phaco group versus the phaco GSL group. So in summary, both procedures lowered the IOP, and there were no real differences between them. Why is this a surprise? Well, the results actually were quite swayed by the two different centers that provided many of the cases. These two centers were from Vietnam and from Singapore. Now, in the Singapore cohort, the GSL was far more successful, whereas in the Vietnam group, phaco was more successful. And because these two studies were the two largest contributors to the numbers, these really could sway the results quite a lot. The baseline IOP in Vietnam was 27, as opposed to 17 in Singapore. So you can imagine that it was much easier to achieve a success in the Vietnam group rather than in the Singapore group. But that still doesn't explain how in the Vietnamese group, phaco outperformed phaco GSL in this group of patients. Now, the other reason why there could be just no difference is because PS does recur at 12 months. And we did another study, an imaging study, which looked at the recurrence of PS over 12 months in these patients who've undergone phaco GSL. It would recur in those places where the PS was removed, not in other places. Also, phaco itself does a good job of removing some of these small PAS. So could it be that we didn't go far enough? Could it be that the next step needed is a iridoplasty to control the pressure better in the longer term? Also, there was a difference in the split of the diagnoses. You can see that amongst all the patients, there was a preponderance of PAC in the phaco GSL group. And in the Singapore group, there was quite a lot of eyes that had no APACs, but still not significantly enough. So in summary, both phaco and phaco GSL lowered the IOP about 30% of patients with primary angle closure disease. Approximately half of the patients ended up with a pressure of under 21 and a 20% reduction of IOP and off all their drops at 1 year. Adjunctive GSL does not seem to have additional IOP lowering effects. This is probably the best study that's been done in its class to find out if this is true or not. Notably, both studies are safe, done with an experienced population. could it be that we should be using iridoplasty as an additional thing in the future to hold those pressures down by keeping the PS from reforming? Thank you very much, and I'd like to invite to APA CRS later this year. Thank you very much.
Thank you, Shamira.